All right, welcome back after our little break. Our next panel is preparing for potential approval of passive immunization products. In follow-up to presentations given at the last NVAC meeting on preventing respiratory syncytial virus infection, speakers in this session will discuss the use of monoclonal antibodies for passive immunization. The session supports work being done in the Innovation and Immunization Subcommittee. We'll hear from Dr. Georgina Peacock from the Centers for Disease Control and Prevention, as well as Dr. Ann Edwards from the American Academy of Pediatrics. Dr. Peacock, thank you for being here with us. You have the floor.
Absolutely, and thank you for having me. So I'm the director of the Immunization Services Division at CDC within the National Center on Immunization and Respiratory Diseases. I don't have any slides. I have just a few comments. This is sort of still in flux, as you know, and so we are watching the developments and the potential uses for nirsevimab for the use with RSV, and as we saw last winter, there certainly was a lot of focus on RSV, and we are very excited about this potential development. So I wanted to talk a little bit about what we have been doing sort of in the background as we prepare and plan for the final decisions that come out related to licensure by the FDA, and then how ACIP will make recommendations after this. So, obviously we are waiting for those policy decisions, and once those are known, we will start implementing the directions of those, of the recommendations of ACIP. And we anticipate that this is going to happen towards the end of the summer to early fall. And then we are also obviously, if there is a FDA approval and then recommendations by ACIP, the other potential that can happen is that there would be a resolution for inclusion in the Vaccines for Children program. So we've had a lot of internal conversations at all levels of HHS leadership, working with the CDC director and others to anticipate what may happen as these recommendations come out. I think one of the things, and Ann Edwards from AAP is going to be talking a bit about the clinical considerations with the potential of this coming out this fall. I think there are quite a lot of challenges that we are working through, and we will continue to work through, because we've got a product that, sort of will function as a therapeutic and an immunizing agent at the same time, or similar to a vaccine, and, thinking through the nuances of that. And then also, because of the timing, we're looking at something that potentially will be approved and not be ready for launch until sort of the middle of this RSV season. So all of those things are within our considerations, and we're paying close attention to what's going on the policy front, and getting ready then in the Immunization Services Division to be ready to implement based on what those recommendations are. So I think, that's what I've kind of got to say today. And then I know Ann is going to talk about some of the clinical implications, and then happy to take questions and maybe explore this as much as we can. So thanks for having me today.
Thank you very much, Georgina. Our next presenter is Dr. Ann Edwards from the American Academy of Pediatrics. Dr. Edwards, I see you on the screen. You have the floor.
Thank you so much, and thank you for inviting me today. First of all, I should start by saying this audience knows how much RSV impacts our infants and young children, the burden on families, based on hospital visits, ED visits, and so we are eager to think about how we might impact that as well. Regarding this specific product, the Academy does not have a formal position or recommendations. We are closely watching and listening and learning as the FDA and CDC continue to review. However, if this product is licensed and recommended, we are working to assure and support that there would be equitable access for the children who it would be recommended for. Next slide. So I'm just going to talk a little bit, like Dr. Peacock mentioned, about how we're thinking about this from the implementation side and that access side. So from a practice level, some considerations. Nirsevimab is being considered by FDA Center for Drug Evaluation and Research as a drug, not a vaccine. That is an important concept, even though we're looking at this as a passive immunization. Next slide. So with this, it has a direct impact on coding. So this is how practices document and get paid. The CPT coding and an AMA decision around CPT codes has been made. This has been classified as a drug and therapeutic. Therefore, it is not in the vaccine chapter for CPT codes. What does this mean on a practical level? It means that there is not going to be an ability to use the vaccine administration codes that include a counseling component. We know and we support that families have questions about vaccines and immunizations, and so spend a great deal of time that's quite important in developing a partnership with families to address counseling, to promote vaccine confidence. And so again, these codes in the drug chapter do not include that counseling component. In addition, this won't be eligible for standalone counseling for those families who may wish to come in and have conversations with a provider in advance of their infant receiving this. Next slide. A little bit about storage and handling. Given our recent experience with the COVID vaccines that had some more unique storage and handling, this product we understand is in pre-filled syringes and administered via IM injection. It is similar to routine vaccine storage and handling that offices are used to doing handling. So this is in a refrigerator at 2 degrees centigrade to 8 degrees centigrade. You do not freeze this. The short-term storage, it can be at room temperature for 8 hours if protected from light, and then its shelf life and expiration is 18 months, so a fair amount of time. Next slide. However, as this is classified as a drug, and when we consider administration, there is the potential for state-to-state variability in which staff can administer this type of product. Can a MA, does it need to be an RN, an LPN? And so we're learning about this, but we know that as we understand that there are workforce and staffing shortages that are significant, in particular in some regions more severely than others, this may impact potential workflows and the ability to have access to this product. Next slide. So just thinking about this from the clinical standpoint, for those infants and young children who might access this through an ambulatory or clinical setting, there is an initial investment by pediatricians, and we are not yet certain on the price for nirsevimab or the demand for this new product. So in terms of planning, we are hearing in the field that people are trying to anticipate what this might be on a very practical level. In addition, just to note that there is always a historical lag in insurance payment for new products. So the timeline to have this in the field may be a bit longer. Next slide. And then if we think about this for infants born in hospitals, we know that bundled payments for newborn care are generally how hospitals are paid. Again, the price of this product is not yet known. But we also know that there's going to be necessary coordination and communication about the administration or lack of administration to primary care for follow-up. So those systems need to be in place. And while we're not talking about this today, there is on the horizon a potential maternal RSV vaccine. We don't yet know, and we are following any clinical recommendations and how that might relate to the infant. But this also has a necessary need for care coordination between the maternal vaccination and the infant's record. And next slide. So I just wanted to add a few slides about what we're thinking about as we implement and support clinicians in being able to provide this potentially. We have an immunization environment that continues to have misinformation and disinformation. So again, going back to the need to support counseling and trusted partners in talking about this product. We do know that the commercialization of the COVID-19 vaccine is on the horizon as well, which is a shift in workflows and creates some workforce, increased workforce needs. Vaccine hesitancy, so this is, again, going back to the counseling. And then we do know that over the past years, we are watching very closely any efforts to weaken school immunization requirements and expand vaccine exemptions at the state level. Of course, this would not be prior to school, but just providing a context of the conversations that clinicians are having within their offices and hospitals. Next slide. And I think that this, we talked about vaccines. This is, last fall, we had an unprecedented surge with workforce shortages. So clearly we want to look at anything that could prevent that, but we know we are challenged there. We are in the middle of a really a mental health crisis with that continuing and not abating at all. So practices really are full in supporting families with that. We are concerned about fatigue and well-being as we implement new products. And in fact, just to note that the AAP is launching a task force on well-being and safety to be able to support pediatricians within their work settings to do the work they need to do. And next slide. I think that is all I have. So again, thank you so much for having me. These are just some thoughts and things that we're thinking through as we watch the data proceed. And I'm happy to answer any questions as I am able. Thank you.
Thank you very much, Ann. And I think it's important as we think about our discussion to recognize that we're in a state of evolution of information about this product. You know, I think the concepts and the discussion are important, but we all have to recognize that the details, regulatory, and a lot of the practice aspects are going to evolve as these products get further along through the FDA process and available. But that said, are there any questions or comments from the members of the committee here in the room or online? Claire? I'm sorry, Molly?
Yeah, to either of the speakers, thank you for your comments. I'm wondering what role you see immunization information systems playing in recording and tracking nursivimab doses administered. And then my other question, let's see here. Also, this seems like it's going to probably be more seasonal. And so do you see it similar to influenza vaccine where there would be pre-booking at a certain time where providers would order, you know, a large quantity for the season, or more like traditional other vaccines that they would keep it on hand year round?
Do I just talk? Yeah, there we go. Okay, so I can start to answer those questions, and then potentially Dr. Edwards has some things to add as well. So, you know, it would be very helpful if these can be integrated into the immunization information systems. I do know that, my our colleagues within the part of the division that focus on IASs as well as others are, I think, trying to sort through, in some states it may be that they can't be integrated into an IAS based on potential state legislation because of this difference in being classified as a therapeutic versus as a vaccine. And so I think there are still many issues to be worked out related to that. I mean, we're aware of them and trying to sort through what that means for the IISs, because obviously it would be very helpful to have something in place so that we can look at administration and be able to look at coverage. As far as seasonality, yes, my understanding from talking with colleagues within the RSV working group at ACIP is that the likelihood is this would be used during the RSV season, so in the fall through early spring, there may be. I mean, again, this is all sort of it's still being worked out, but there could be a recommendation for infants possibly getting it in a birthing hospital versus in an outpatient clinic. And so once those recommendations come out, we would then look at whether. And then, of course, the other question is, will this go through VFC or will this go through a different kind of mechanism? And then we would look into whether or not it's a kind of a pre-booking situation or how we would do that. We also know, so I mentioned, the likelihood is that this will sort of come maybe mid-season. Given where we are right now. And so what it looks like this season versus future seasons may be different. And so I think we need to, prepare the immunization community and also the clinical community that maybe there will be kind of a slow ramp up to this, meaning, I don't think we know what the uptake will be initially. Usually with a new vaccine or a new immunizing agent, it does take some time for there to be adoption of this to get to the coverage rates that we're interested in. And so that will be taken into account as well as we're planning for a potential rollout of this season. I don't know, Anne, Dr. Edwards, anything else to add?
Yeah, thanks. I think you covered a lot. I think we're at the position of kind of planning for different scenarios based on, again, when the licensing and whatever recommendations might come out. We would, yes, IIS, that would be preferable, but as mentioned, that may not be possible. So what does that mean for jurisdictions for which that could not be used? I think we don't know that answer. And I think I think that we have heard some practices thinking about this like a flu season or that seasonality. To remind us all, we're not quite sure what the RSV season is. Is it going to go back to where it traditionally was or not? So I just will raise that question, and others who follow that epidemiology can probably speak to that further. But also noting that it will take some time to kind of get this in the field, but as we understand, depending on what the clinical recommendations are, it will be potentially a little bit, maybe a younger cohort of infants. So while we may have some clinics like we do with flu season, I think clinics will have to be prepared throughout a longer period of time to be able to provide this product, either if it's in the outpatient clinical setting or, again, if it happens to be in the hospital setting. And yet we also don't know about a year or two for high risk infants and children that maybe have traditionally received palliativimab. I have not raised that question, but I know that we're following that information closely to understand that as well.
Claire, you had your placard up earlier and you put it back down. So.
Thank you. Yes, it's Claire Hannon with the Association of Immunization Managers. We've been working really hard to sort of let immunization program managers know this is coming and help them to be aware. It does take some time, obviously, to implement. And so I think any amount of time that we know in advance helps to add a vaccine to IIS, to add it to an ordering system, to start educating providers, as you both discussed. I'm just wondering if you could shed any light, if you know, who will make the decision about whether the vaccine will be in VFC or not? And, because we seem to be in the wait and see, and it's just very difficult to prepare in the wait and see mode. So I'm just trying to understand who is going to make that decision.
So I think, it's within HHS. I mean, there's been conversations happening at all levels up to the secretary's level. And so, what we can't do is get out ahead of the FDA and the ACIP. And so, but we're preparing for that.
Courtney?
Thank you. This is Courtney Londo, American Immunization Registry Association. And I just wanted to comment on the current state of IIS capabilities. So currently not all IIS are able to capture the administration of passive immunity products. And these products, as mentioned from the presenters today, use different code sets than those that are traditionally stored in an IIS. So given that EHRs are one of the primary sources of data for IIS and use the same code sets, the linkage between EHRs and IIS will be critical to making this happen. Often EHR products have to be modified to send new and different codes, and that might be subject to how the products are installed at the local level. So that linkage will be critical. One other thing to consider from the legal perspective is that often the definition of vaccination or immunization can determine whether or not these products can be included in the IIS. So it's going to take some time for that ramp up, but those are some considerations.
I mean, yes, that very well said. I mean, there's a lot of complicating factors with this particular product, and I think it's both exciting to have something that is different than what we usually consider in the vaccine space, but also I think we are working through the complications of this with both internally to the federal government and also with partners like you all to try to make sure that there aren't whatever can be mitigated as far as roadblocks are not there. So I think continued conversation about this so that we make sure that children can get a really important product. I think it's important.
This is Steve Renderneck, one of the members and a practicing pediatrician. As I listen to this, I'm trying to think through the practical aspects. This is really complicated. My understanding is that babies born October through April will get a birth dose, so most likely a hospital administration. Communicating that to the different offices for follow-up appropriately, and is it going to be compatible with the potential maternal vaccine that was given at the same time? To coordinate the EHR and communication there can be a challenge. Not that we can't overcome it, but it is complicated. And there's no other vaccine other than the flu vaccine. So babies that aren't born during the season will come around that following probably October and be due for their dose. That may not be at the time of a scheduled well visit for that infant when they're used to coming in for all their other shots. So trying to communicate that through portal messaging, I'm just thinking, I'm thinking through what we need to kind of anticipate, knowing this is on the horizon, and the many things that you brought up already and things that are being worked out. It's wonderful to see that in, proactively looking at it. But I just want to throw out those other comments, that things to consider. Thank you.
I'll add one other complexity to add on top of that is we have a relatively mobile society, particularly a lot of families who have young children. And so, the potential of a personal record that could go with them and not disappear with a change in telephone would be another piece to think about.
Yeah, I guess I don't have answers to all of you, the questions that you pose, but I think, certainly in the awareness of as we're thinking about this, and one perspective that I have or we have from the Immunization Services Division is the easier the implementation, the greater the uptake. And so as, we put together an implementation plan, I think that is one of our guiding factors is, when you have a lot of nuance of, what the impact of knowing or not knowing if the mother potentially got a vaccine, or if a child gets it, an infant gets it in a birthing hospital versus in an outpatient clinic, decreasing complexity in the implementation is important, and definitely is something that is going into our thinking as we think through the potential implementation.
Thank you. And just to add to that, we're obviously thinking a lot about all these practical implications, gaining input from our experts and people who constantly think about implementation like this. I think it's also going to rely on strong partnerships, and I'll say partnerships within a community. So thinking about hospitals and practices and how we coordinate, but also at this level, to Georgina's point about how do we provide as clear, consistent communication out to individuals so that we can implement as efficiently as possible, even though the complexity exists. So we've learned a lot over the last 3+ years about how to do and continue to improve upon that. So just lifting that out and look forward to those continued partnerships as we think through all of this.
Well, thank you both for your presentations, and thank you for discussion. We've got a question from Jeff Dushan on the line.
Thank you for your presentations. I'm wondering if you could say a few words about what you see as the role of our local and state health departments in the implementation of passive immunization products, and particularly the product that we're discussing now for imminent implementation, and what resources may be required at that level. Thank you.
So I think, from our perspective, that depends on, the recommendation that comes out from ACIP and whether or not that would be included in the VFC, the Vaccines for Children program. If it is included within the Vaccines for Children program, there would be, the resources that we provide to immunization programs across the country and at the state and local level, would we would use that mechanism in order to support the rollout of essentially a new immunizing agent within the VFC program. If it's not through that mechanism, then I'm not sure that I can speak to what the role of the state and local health departments would be, but if it's through VFC, then we would be rolling this out as we would a new vaccine or a new immunizing agent, similar to what and I'll talk about this afternoon, but similar to what we're doing as we're anticipating the commercialization of the COVID vaccine and the fact that that's included on the routine schedule now.
Thank you. That's helpful. Do you anticipate any increase in resources available to do this work if it does go through VFC?
I don't think I can speak to that at this moment because we don't have the recommendation yet.
Okay, thank you.
Again, thank you for your presentations. Lots of good discussion. At this time, we will close our morning session and break for lunch. It's now 10 minutes to 12 Eastern Time. We will return promptly at 1:15 Eastern Time for our first post-lunch panel, the big catch-up, restoring vaccination rates. Thank you all for joining us for our June NVAC meeting. Good afternoon. Welcome back to our final panel for the June NVAC meeting. Our next panel is the big catch-up, restoring vaccination rates. In this session, we'll focus on how immunization programs are shifting to more emphasis on routine immunizations in a post-pandemic world. And I'll invite our speakers to come to the stage. Our speakers include Tosin Ajayi from the Clinton Health Access Initiative, Dr. Georgina Peacock from the Centers for Disease Control and Prevention, Dr. Meredith Allen from the Association of State and Territorial Health Officers, Matt Bobo from the National Association of County and City Health Officials, and Claire Hannon from the Association of Immunization Managers. Tosin, you may begin your remarks. Thank you.
Thank you so much. It is a pleasure to be here today. Good morning, good afternoon, good evening. I'm calling today from Lagos, Nigeria. It's really a privilege to present. My name is Dr. Tosin Ajayi. I am the Technical Manager for Immunization Service Delivery and New Vaccines Introduction at CHI, Clinton Health Access Initiative, and I'm on the Global Vaccines Delivery team. I recently co-authored an article that was published at the Vaccines Journal with other colleagues and really on the topic of recovering from unprecedented backsliding in immunization and spotlighting learnings and experiences from CHI's country programming in 5 countries and throughout the first 2 years of the COVID-19 pandemic. And I'm here to share with you today global perspectives on restoring vaccination coverage, which has been termed the big catch-up. For just a bit of context into what informs the perspective that I'll be sharing today, and also provide some background into the geographic area of focus that CHI's Global Vaccines Delivery focuses on. We are present in 35 countries across the world. However, our global and regional, as well as our country immunization programs, have supported over the last 10 years about 15 immunization programs in Sub-Saharan Africa and Southeast Asia and Pacific. And I will do my best to keep my video on throughout this presentation, but it is late evening, and if I have network challenges, I might have to turn it off. But it's really a pleasure to speak to you today. If I can have the next slide, please. Thank you. So from a global perspective, it's no longer news the unprecedented effects the pandemic has had on health systems, one through the associated disruptions in the health space, as well as the subsequent rollout of the COVID-19 vaccines, which was the largest vaccination rollout that we've seen in this lifetime. And this has resulted in a jeopardization, I would say, of decades of progress within the immunization landscape and strains not only the health systems, but also the economic systems. And even up to this present time, we still continue to see the effects of the pandemic. Globally, we have observed sharp declines in coverage in 2020 and 2021. And from a global perspective, while we are still awaiting the release of the global coverage estimates for 2022, we're indicatively aware that many countries will still not have recovered to pre-pandemic levels. In 2021, where we have a cross-cutting data set available, where we know that 25 million children were unvaccinated or under-vaccinated, which is 6 million more than it was in 2019. Of these 25 million children, 18 million of them were considered zero-dose children. And these are children who are considered to not have received any vaccines. And the indicator that is used to track this is the first dose of DTP vaccine. And just to provide a bit of context, and which is what you see on the slide, is this is the same level we essentially were in 2005. So that's essentially a 16-year setback. And when we look at other antigens as well of importance, measles as an example, in 2021, we also see 5 million more children compared to 2019 who did not receive at least one dose of the measles vaccine. And this has resulted in significant immunity gaps and subsequent outbreaks in many countries, especially in Africa and the Eastern Mediterranean regions. And I think we've also seen similar in the US as well, maybe at a smaller scale. And when we also look at the HPV vaccine, it's also experiencing a downward trend. And we've observed about 3.5 million more children who have not received HPV vaccine in 2021 in comparison to 2019. If you can have the next slide, please. And I won't spend too much time on this slide, but I just wanted to highlight the double burden, which I just referenced, that countries are facing, and which is resulting in this continued and unrelenting backsliding that we're seeing. At the beginning of the pandemic, just to put a bit of context here, at the beginning of the pandemic in 2020, up until early to mid 2021, depending on when countries really started to receive the COVID-19 vaccines, health services were suspended in many countries. And when the services were actually available, people were concerned about visiting health facilities due to either movement restrictions, depending on how long the lockdown was on for, but also just the fear of contracting the COVID-19 virus. And in addition to this, across the world, there's significant repurposing of resources, both human and financial resources, at all levels of the health system towards the pandemic response. By late 2021, up until present time, when the vaccines were introduced, many low and middle income countries were overwhelmed and continue to be overwhelmed by the additional burden of carrying out the largest vaccination rollout we've seen. And as we move into the second half of this year, COVID-19 vaccination still remains disruptive in many countries. For example, healthcare workers are still being pulled out of the facility to conduct nationwide COVID-19 vaccinations in some countries. So many countries are still struggling to integrate COVID-19 vaccination programs into their routine immunization systems or even the broader PHC primary healthcare system. And even now that the acute phase of the pandemic is over and the focus shifts away from the general population towards the highest risk groups, this continues to be a source of concern and strain for a lot of healthcare systems. Next slide, please. And maybe just to reference a little bit the big catch-up, and this is in response to the persistent decline in coverage and the significant backsliding that we've observed about the last 2 to 3 years. The global immunization community has commenced a global drive to immunize 6 to 7 million children globally between 2023 and 2025. And the goal here is to bring immunization back on track towards achieving the goals laid out in the global immunization agenda, which includes a 50% reduction in the number of zero-dose children. This, like I mentioned, has been some of the big catch-up. And the focus is on 20 countries that account for almost 80% of unvaccinated children globally. And these countries have been tasked essentially to create tailored and context-specific recovery plans to support their ambitions to not only catch up, but also restore and strengthen their immunization programs over the next 2.5 years. Next slide, please. And I believe it's also really critical to mention that while there is this urgent need to close immunity gaps and restore coverage from the effects of the pandemic in low and middle income countries, and all countries actually, the emphasis must not only be on short-term solutions, but also on building back better systems to address the underlying weaknesses that existed even prior to the pandemic, and also enable immunization programs to withstand any future inevitable shocks or interruptions. In the short term, the activities that have been listed out are predominantly centered around catching up not only children under the age of 2, which is the typical cohort in many countries for immunization, but also children who might have aged out of the typical cohorts, and sometimes even up to 5 years old. And this is being implemented majorly through single or multi-antigen campaigns, or through intensified defaulter tracking mechanisms to be able to reach the children who've been missed. And also with the long-term outlook, there's a need to continue to support countries to move towards a true life course approach as part of their essential immunization program, which also requires the involvement in some cases of the broader health and non-health stakeholders, as well as investments needed for real systemic transformation that incorporates resilience into the immunization program. Next slide, please. And maybe just to highlight some of the insights that were in the article that I referenced at the beginning of this presentation, I've put the link up here at the top left corner. And just to provide a bit of context here as well, this article was born out of the realization that there was not a lot of evidence on what exactly countries were doing to recover from the effect of the pandemic. At the time where we wrote this, the 2021 global coverage estimates had just been released in the middle of 2022. And from what was shared or what was spotlighted, there were a handful of countries that had started to recover from the pandemic, while majority of countries were still lagging behind in terms of their coverage. And as a result of that, we decided to investigate and explore the topic a little further with a number of our country colleagues who are typically embedded within immunization programs in the countries that we support. And to do this, we leveraged the key actions for sustainable global immunization progress as a framework. This was published in The Lancet by other immunization experts. And we used this to spotlight examples of the strategies that were being used by 5 CHI-supported countries: Cambodia, Cameroon, Kenya, Nigeria, and Uganda. And we use this really as an opportunity to provide examples and also inspiration for other countries who are looking to maintain, restore, and strengthen their immunization services and also catch up with children in the context of pandemic recovery, and to direct their focus towards building back better the resilience of the immunization systems and to be able to respond more rapidly and effectively despite the new and emerging challenges that have come to bear. And it's critical to also mention that these countries were selected because they exhibited exemplary performance in strengthening their routine immunization programs and had restored lost coverage levels in the last 2 years. And I'll just maybe talk through these 5 pillars that I've spotlighted here. So first was around the frequency and approach for catch-up. And what we observed is that across all the countries that we did spotlight, it was not only important to conduct those catch-up campaigns, but the frequency and the approach also really mattered. So for example, in Cameroon, we observed that they had utilized a data-driven approach to conduct multiple rounds of campaigns with a focus on the areas that were affected by conflicts. And in addition to that, they were able to intensify their surveillance approach as well to really be able to understand the different nuances within the immunization program as they deployed it. Number 2, I would say, is also the importance of strengthening the health information systems. And this is also an example that we saw across all the countries where they found that it was important to collect more frequently data, not only to collect data more frequently, but in some cases required adjustments to their information systems. But they also reviewed and analyzed the data more frequently as well to be able to iterate on their approach. Number 3 is around finding synergies with the COVID-19 rollout. And we found great examples from these countries of being able to utilize the COVID-19 vaccination rollout to strengthen their broader immunization system. And in the case of Nigeria, which is spotlighted here, they developed a holistic strategy for delivering COVID-19 vaccines, as well as other RI vaccines and PHC services using a family-centered approach. Similarly, we saw in Uganda the use of the need for frequent trainings during the deployment of the COVID-19 vaccines to be able to upskill their healthcare workers on a variety of immunization topics. Number 4 here is around the mobilizing of resources to sustain immunization. We saw examples of countries really taking advantage of the momentum and the attention brought about by the pandemic to the health, to engage non-traditional players in the health or the vaccine space. And we have examples from Uganda as well, where they were able to, across all levels of the health system, engage a variety of stakeholders, both public and private, to support the strengthening of the immunization system. And lastly is the restructuring of health systems to build resilience. And this is another observation we saw in all these countries, where there was an intentional restructuring of the health system towards a more user or community-centered approach. And an example here is from Cambodia, where they are currently strengthening their policy around community participation to be able to truly have the community be in the center of decision-making for how health services are delivered. Next slide. And I just wanted to take a moment as well here to highlight some CHI's immunization priorities in the delivery of immunization. And I would say one is really around supporting these countries, these focal countries, the 20 that I mentioned earlier, to be able to develop their recovery plans, update their policies, and also secure additional vaccines and resources needed to be able to reach the unreached and also children missed as a result of the pandemic. In doing this, we're also placing a huge focus on zero-dose children to be able to prevent and mitigate backsliding of immunization. And core to our strategy here is creating a robust evidence base for equity to identify unreached communities and also employ a bottom-up approach to integration and really be able to leverage all opportunities where children come into contact with the health system for immunization. And lastly, and beyond that, is also to continue to support the broader immunization and health system strengthening towards the support to introduce new vaccines and close the gap in select countries with high impact and life cost vaccines, strengthen the last mile stock availability, especially around cold chain investments to build a stronger health system, and finally, embed a focus on management systems and capacity building that supports the programmatic and financial sustainability of the immunization system. Next slide. Thank you. Thank you so much for this opportunity. It was a privilege. Thank you.
Thank you very much for your presentation. Our next presenter is Dr. Georgina Peacock from the Centers for Disease Control and Prevention.
Okay. Hi. Well, so I'm back here again, Georgina Peacock from the Immunization Services Division at CDC, and just to sort of provide a context of where I work, we have a mission to protect individuals and communities from vaccine-preventable diseases, and we do this within the division by provision of federal funds and contracts to purchase vaccine and distribute vaccine. Provision of technical assistance and financial support of the immunization programs, so the state and local health departments, as well as national and community level organizations. We also do work related to provider and public education, and then evaluation and research. And so that's the sort of the purview of where we are in ISD. And then other parts of the National Center on Immunization and Respiratory Diseases do more of that research and evaluation, as well as we work collaboratively on things like measles outbreaks and polio and things like that. So, and at the core to the work that we do is vaccine equity. So with the principle that everyone has fair and just access to vaccination, and that really helps us inform our activities and our programs. So the Vaccines for Children program, which you all are very familiar with, is really the cornerstone of our work. And we're coming up on the 30th anniversary of the VFC program. It was enacted in 1994 to provide access to all ACIP recommended vaccines for the most vulnerable children and adolescents in the United States. And so currently provides approximately 50% of vaccines for children in the U.S. Through this provision or this expansion or improving vaccine access, VFC has been able to increase vaccination coverage rates, reduce the incidence of preventable diseases, vaccine-preventable diseases, and then reduce disparities in coverage. And you'll see some of these numbers here, and we update this infographic about, I think, every 2 years, but we've prevented 472 million illnesses, avoided over 1 million deaths, and saved nearly 2.2 trillion in societal costs since the inception of this program. So in addition to the VFC program, we see that as a piece of a comprehensive domestic immunization program. And you'll see here some of the other components. Some are proposed and some are there already. So the VFC program, which I talked about, then the Section 317 of the Public Health Services Act, that is sort of the discretionary part of the funding that provides that work, the infrastructure, so internal to CDC and then externally, as well as, funds for research, for vaccine safety and efficacy, and then to be able to look at outbreaks. And then this third part of this puzzle is the vaccines for adults. And so the vaccines for adults program as a proposal is in the president's budget. And so that is not a program that sort of exists right now, but we do adult immunization work. And so we work through our 317 discretionary funds to try to provide some access to routine immunizations for adults through our immunization, the immunization programs that we support. And so when we look at the sort of all of these different pieces, this is what we view as our goal, which is working towards a comprehensive immunization program that serves people across the lifespan. So I'm going to talk now a bit about the effects, and this is not a surprise or probably not even a new slide to you all, but I wanted to take you back to 2020 and just remind us of what happened to vaccinations, routine vaccinations for children during the pandemic. And one way to look at this is by looking at vaccine ordering, and you'll see this dramatic drop in March of 2020 that showed a dramatic drop in vaccine orders for the Vaccines for Children program. That was a time when children weren't getting well visits. There was a disruption in the healthcare system. And so we started at that point, or likely before, but monitoring vaccine coverage and looking at what the impacts were and sort of predicting that we would see drops and thinking about what we would do to regain that vaccine coverage. So what are some of the things that we saw? We saw that and this is national interview survey data, we saw a 4 to 5% drop in the seven vaccine series coverage among 2-year-olds that lived in poverty or in rural areas. We also, if we look at another data source that we monitor, we saw in a 2-year time span about a 2% drop in kindergarten coverage rates. So went from 95% to 93%, which, a lot of people would say, well, that's still really high, and it is really high. However, that accounts for about 275,000 children who entered kindergarten in the 2021-2022 school year who didn't have documentation of those required vaccines, so potentially we're entering kindergarten without that, preventative vaccination for vaccine-preventable diseases. What we need to also remember was we still have, in the big scope of things, really good coverage, right? We have about 9 out of 10 children at their 2-year-old, at 2 years old having routine vaccinations. So then when we go and look at adolescents, we saw similar declines, depending on which data source, again, that we look at. If we looked at the National Interviews Survey teen data, saw about a 4 to 5% drop in men ACWI and Tdap. Looking at another data source, we see in vaccine ordering a fairly significant drop in HPV. What we're seeing, and I should have mentioned that in our childhood vaccination, but also in our adolescent, is that we are seeing a rebound in a number of these vaccines. One notable exception is among adolescents and HPV. Again, when we look at the positive side of routine adolescent vaccination, we are seeing, we still have nearly 9 out of 10 teens that have their men ACWI and also Tdap, and then about 8 in 10 have had their first dose of HPV vaccine. continuing sort of across the lifespan. As I said, we really are looking at the work that we do to support vaccination across the lifespan. This shows you that we had made steady increases in our in the vaccination of adults in this country, and again, that was impacted due to delays in preventive care, disruption of the healthcare system, and I think very significantly vaccine confidence in routine adult vaccination. And so, definitely a lot of work to do there as well. So when we think about some of the successes and challenges that occurred for our vaccination program during the pandemic, we made a list of some of the challenges and then sort of what we are thinking about as lessons learned or things that we need to do as we move forward. You'll see some of these displayed here. So as far as communication, reminded us, or the thought that we need to promote plain language use, modernizing data collection and clearance, and then definitely using trusted messengers. Another challenge was the complex and challenging guidance that was provided. And one of the things that's happening in the CDC moving forward effort is a restructuring and a streamlining of CDC's website. There will be something, it's called Clean Slate, and they are looking at essentially redoing the entire CDC website over the next year or so. Hard to reach populations. This is not new to vaccination, but certainly was highlighted in the pandemic that it was important to partner with organizations who serve or represent individuals. We did a lot of work looking at working with community-based organizations. They might not be health organizations, but they were organizations that served populations who maybe didn't have the information related to, either specifically to COVID vaccine or to that more general information about vaccine confidence. And partnering with these types of organizations is something that we did, and we need to continue moving forward. Which really sort of summarizes that first point up there. So partnering with trusted messengers, increasing access to vaccines. You're more likely to have confidence, or you're more likely to get a vaccine if you have more broad access to those vaccines. And then, of course, and we heard, I know there were some talks yesterday and then also earlier today about the really important effort to address mis and disinformation. Vaccination fatigue, I know you heard about that a bit yesterday as well, is a real thing. And so we, need to both think in the COVID space, but also in that routine immunization space about, the clear communication that is needed, the normalizing of routine vaccinations, and again, addressing the mis and disinformation. And then in the COVID space, pediatric vaccination was not broad within COVID vaccination, and sort of thinking about conversations with doctors and nurses who recommend vaccinations. We know that they are the trusted messengers, and then leveraging what we can within the Vaccines for Children program. Excuse me. So these are some of the things that we are doing at CDC. The first here listed is the Let's Rise initiative. And, what we are doing is looking at the data that we have. Someone mentioned this morning the immunization information systems. So information coming from those vaccine administration systems, also, vaccine administration data, as well as looking at national interview survey, looking at other data sources, and trying to pinpoint where we're seeing decreases in coverage. If we look broadly, like I said at the beginning, we have very high vaccination rates in this country, but there are pockets in areas, either geographically or in populations, or particular vaccines where we're not seeing as high coverage. And so being able to look at data to target interventions in different ways is really an important thing for us to do. We are working with our state partners in immunization programs to look at, what might be the most effective strategies in a certain place or a certain vaccine or a certain population. And so that's really sort of the essence of the Let's Rise initiative. In addition, we have reactivated the Let's Play Catch-Up communication campaign. So there have been a lot of paid media targeting of these messages over the last couple months in select markets, and those are associated with some of the areas that we are being highlighted with our effort within Let's Rise. And then in July to September, we'll be using the basis of this Let's Play Catch-Up campaign in a back-to-school campaign. And these media assets will be available for people to tailor to their organizations as well, or sort of their areas. And then we will also be placing, the communication assets in different markets to try to reach different audiences. And then finally, I mentioned to adult immunization, again, promotion of routine adult immunization, as we hope that we'll see catch up and just increases in that area. So just to mention, I think I'm talking to an audience who knows this, but just to reiterate, no matter how many times this data is looked at or, focus groups are done, all of that, we know that the trusted messengers are healthcare providers. There's those nurses, those doctors, the other individuals that interact with people in the healthcare space. And so one of the things that was published, so an MMWR was published in February, which looked at healthcare provider recommendation of the COVID booster vaccination. And what was found in that particular MMWR was that a person was 13 points higher, or 13 percentage points higher or more likely to get vaccinated if they received a recommendation from their provider. So I'm going to now move to where we are now. This shows VFC provider orders over since 2019. And just to orient you to this graph, the orange is essentially the first part of the year, and then the hashed blue area. So orange goes fiscal year. So orange is October through May, and then the hashed blue areas are June through September. And using FY19, which is over on the over here on the left, is what we were in FY19. You can see those drops in fiscal year 20 and 21, and are starting to rebound in FY22. And so then if you look here in fiscal year 23, we are still not quite where we were in fiscal year 19, but we are seeing increases in these vaccines for children orders, which is one way we monitor what's happening related to, catch up on vaccinations. So it's reassuring to see. Obviously, we need to keep looking at different data sources, and I think, as I mentioned before, we have seen more catch-up in certain vaccines than others, and more catch-up in different ages than others. A minute to talk about COVID vaccination moving forward. There's a big focus right now on moving towards commercialization of COVID vaccination. So what that means essentially is that there will be public payers and private payers for the COVID vaccine, and vaccines will remain free of cost to most U.S. residents through either Vaccines for Children, the Children's Health Insurance Program, most commercial insurance, Medicare and Medicaid programs. What we also know that we need to do is continue to focus on vaccine equity. And what comes into play for that is the Bridge program that was announced, which is a program that is being run by CDC, but announced by the HHS secretary to provide that COVID vaccine for uninsured Americans. So it's about 24 million adults are targeted with the Bridge program. The people who participate in the Bridge program will be able to get vaccines through a few different ways, either through our typical safety net, what we call our 317 program, so through health departments and providers that are enrolled as part of our immunization programs or part of those health departments to get vaccine. There will also be access at federally qualified health centers that will work through that same program. And then there will be the ability to access vaccine through certain pharmacies. Not everything is in place yet. It's all being put into place, getting ready for the commercialization of the vaccine that should happen in the fall. And then with all of this, of course, vaccine confidence is key. And so to end this talk, I just wanted to show you the framework that we are working through for vaccine confidence, which, focuses on three main areas, protecting communities, engaging providers, and then stopping myths, or really addressing that myths and disinformation. So thanks for your attention today, and I'm happy to take questions after we get through the panel.
Thank you very much, Georgina. Our next presenter is Dr. Meredith Allen from the Association of State and Territorial Health Officers.
Good afternoon. Thanks so much for having me today. And it's exciting to be such a part of such a great panel. I look forward to hearing everyone's remarks. One thing I did want to share is I think as you kind of go through our presentations, you'll hear some overlapping common themes that are going to pop out as lessons learned. And so I think it's a good thing, actually, in that we're all at different levels of government seeing similar themes and similar things that at least we're aligning on kind of where we're working and where we're focusing. So I think some of those things will come out together. So my name is Meredith Allen. I'm from ASTO, and I'm looking forward to sharing with you a little bit about the state perspective today as we're moving forward in looking at regaining vaccination status post-COVID. So first, a little about ASTO. We're a nonpartisan organization representing state health officials across the country, 59 states, territories, and freely associated states, as well as Washington, D.C. So we have a variety of different members, rural states, urban states. We cover the gamut. So there's a lot of different things that we're all looking at across at ASTO. Our members are really responsible for formulating and influencing public health policy within their jurisdictions. They collaborate quite closely with their legislature, governor, and other public health professionals. We assure excellence in state and territorial-based public health practice, and also look to really provide public health and health expertise, not only to our members, but then also so they can provide it to their elected officials. I did want to stop and before we move on and talk about lessons learned and gaps and things that we need to change or do better or do differently, I wanted to acknowledge the great effort and the great success we did have in the COVID-19 response. Throughout state and territorial health agencies working with healthcare in local public health and federal public health agencies, we vaccinated 81.4% of the population. That isn't a heroic effort. It has been done in a timeline that was never seen before. So I think it's important that while we move forward and we're talking about how we can change and do things differently, that we do keep that in mind and that we were successful in such a huge heroic effort. We saved over 2 million lives, prevented over 17 million hospitalizations, prevented over 66 million additional infections, and saved over $900 billion in associated healthcare costs. So that was a huge, huge effort. So if we move forward, do want to keep that in mind as we're looking. So as we're looking ahead and retransition our efforts really to thinking to how can we increase routine vaccination uptake, we want to build on the lessons that we've learned from COVID. And you can see that there's really three things here that we're looking at. Building on those lessons that we've learned and thinking through them. Acknowledging that the landscape in which we're currently working has changed. We're not going back to a pre-COVID world. We're in a new kind of different society, different world, and we need to make sure that we're operating in it appropriately. And then finding a way to move forward in that new change side. So some of our lessons learned. These are really stemming from the successes that we've had through COVID vaccination and things that we should most likely keep that we did differently throughout COVID. During the pandemic, many health departments worked with and implemented mass clinics, mobile clinics, worked with different partners. We really tried to meet people where they were. We didn't try to draw people in for vaccination. We went out and found them. And I think we did that in a way that we haven't really done quite as in such a huge effort in the past. And I think that was something that worked really well and something that we need to look forward and try and figure out how we can continue those types of efforts. Dr. Peacock also talked a little bit about partnerships, and I think we had some really inventive partnerships, even stemming back to the H1N1 response and COVID. Again, community health organizations and community organizations in general, whether they were health related or not, were a huge change and made a huge difference in the impact we were able to have in communities. Working with communities together and really planning together and figuring out how we could reach everyone in the community was a huge success through COVID, and I think it's something that we need to stay. It needs to stay and needs to change as we move forward. We also had trusted messengers. Another thing that we mentioned a little earlier is finding those trusted messengers, working with the community to ensure that they're in the community, but also looking at our healthcare as trusted messengers. Engaging with a wide healthcare provider community was something that we saw that was a little different. During the pandemic, I think we kind of broadened who we saw as part of our group of immunizers or the healthcare community. We really looked at pharmacists, and they took on a large role in those vaccination efforts. And now that we're moving towards routine vaccination, how do we continue with an expanded network? What's the appropriate network to have? When is it appropriate to use this expanded network? But how can we capitalize on what we've already built? We're recognizing, obviously, there's some barriers to this, and there's a lot of barriers for providers, limited scope of practice for vaccines, financial barriers, upfront costs. Providers also often have a limited time in their visits, but really ensuring that we're able to work in those vaccine conversations, even amongst this vaccine fatigue that we're seeing among providers as well as their patients. And we also know it's important for health agencies to offer opportunities to engage with providers. Two-way conversations, as we mentioned earlier, between a patient and a provider is the #1 way to motivate towards vaccine. It really is the place where those decisions happen, and you can really change some minds. Multilingual media and communication strategies. As we saw through COVID, there was a huge effort in communicating with the community and about the vaccine, what it was for and why. These campaigns were effective during the pandemic, and it's something that I think we need to continue as well and really keep those broad access. Obviously, IIS was an essential tool during the pandemic, and we need to continue to make sure that we're supporting and building our immunization systems as well. So our landscape has changed as well. The COVID vaccine changed how we communicate with the public around vaccines. There's a different awareness of vaccines than I think there was previously. We've been working on a project with Harvard and the National Public Health Information Coalition, NVAC, along with CDC, to do some public opinion polling. And we did this project throughout COVID. And we've heard a lot around a loss of trust in government and the public's loss of trust in public health and governmental public health. But what we've seen is that there still is a trust level there with public health. They still do find health agencies and state and local public health and federal public health agencies as a trusted source of information. And so it is important to, while we may have kind of had a little bit of a backslide, we still are seen as trusted messengers. Our agencies are trusted messengers, and it's important that we're communicating out. There's also a little bit more of a discussion we're seeing around personal and parental rights when receiving vaccinations. We need to consider this in our knowledge and kind of how we're communicating and what we're seeing, but also acknowledging that we're also seeing the opposite as well. Parents are having conversations around their rights to have their children in kind of preventable disease-free environments as well. So there are two sides to that conversation around parental rights, and we are seeing both sides occur. So moving forward, there are many public health initiatives that were neglected throughout COVID. It's difficult for health agencies now as they're moving forward to try and come back to some routine operations post-COVID to really figure out how to prioritize and what to prioritize. Obviously, we're seeing huge issues and needs around mental health, the opioid epidemic, chronic disease, trying to figure out what we're doing around long COVID is a conversation that's occurring. So routine vaccination is one of the many initiatives that public health needs to prioritize as we go forward, but recognizing it's among many of the things that they are trying to prioritize and scale back to a reasonable level. Same thing is going on in the healthcare industry and healthcare providers. Many things were delayed in kind of that public health or pandemic debt that they're seeing. People didn't go to the doctor, they're seeing new conditions, people are further along in conditions than they would have been prior to the pandemic, given that they delayed care. And so they're getting that vaccine conversation, especially in the adult space, back into that provider conversation is going to be something we'll need to work with as well. We're also seeing a changing legislative landscape, which I can talk a little bit about. In 2023, there have been over about 500 bills identified that came up in state legislative sessions that would impact vaccine access. By late April, only about 17 or 3.5 were actually enacted, so the majority of these bills are failing to proceed all the way through. There were some positive bills as well. The majority of them we would categorize as negative, but some of the positive bills were really working to increase access to vaccines, and we're looking at expanding that scope of practice. That's where we were seeing more of that expanding access versus contracting. The negative bills we were seeing ranged the gamut. I mean, there were a lot of interesting things that came up in our policy scans. 2 states would have repealed vaccine requirements for school enrollment altogether. So we are seeing things that would completely repeal any type of vaccine requirements for schools. We're also seeing bills that have come up that would take away from the health department any responsibility or even requirement in involving the health department in determining which vaccines should be required for school, if any. Again, these bills did not move forward. They were able to be pushed back, which is great, but the fact that they're even entering discussion is concerning, obviously. So it's something state health departments and our membership are spending a lot of time working against these bills kind of behind the scenes to make sure that they don't advance. So where do we go from here? I think it's important that we reflect on our accomplishments. Again, as I stated in the beginning, we did have huge success, even though it may not always be portrayed that way throughout the COVID pandemic. We did have a huge success in vaccinating the population, and we should learn from our best practices that we instituted then. We really did have a whole of government and a whole of community response to COVID, and making sure that we're building together forward what our continued routine immunization system is going to look like. We need to make sure that we're looking at things a little differently, as you know, we are in a new landscape, things that we may need to adjust our language, we may need to adjust how we say things or where we're saying things, or bring in new partners to help us carry that message where we can't carry it. But I think we're open at this point to kind of all the different options. And then, of course, resources. This is something that we talk about all the time. There were a lot of resources that came with the COVID pandemic and the response. And as those resources are either dwindling or ending, it's going to be important that in order for us to maintain any of the partnerships and the staffing and the levels and the data and the immunization streams and the systems that we've got going and built and furthered during COVID, to maintain them and to continue and further them along as well, we'll need some resources to be able to do that as well. I'll be happy to take any questions along with the panelists after our next presenters.
Thank you very much, Meredith. Our next presenter is Matt Bobo from the National Association of County and City Health Officials.
Good afternoon or good morning, depending on where you are. It's very nice to be here. I'm Matt Bobo. I am a Senior Director of Immunizations and Maternal, Child, and Adolescent Health at the National Association of County and City Health Officials, which we also call NACCHO. So I'm here to talk with you today about NACCHO, just to kind of level set with everyone. So NACCHO was founded in 1965, and it has over 3,000 local health departments or cities. And really what NACCHO does is it functions like a state health department. There's an immunization program, there's a maternal child and health program, environmental program. So a lot of programs that very mimic what a local health department would be. And a lot of the stuff that we do at NACCHO is we receive cooperative agreements or funding from CDC, other organizations, and then we transmit those funds to local health departments and cities to innovate best practices with immunizations and see how we can build confidence and what are some of those things that work in a rural area could maybe work in another rural area and vice versa. So really trying to see what we can do to increase coverage rates. So just kind of talking about some of the projects that we have going on now, which it all depends on what funding and what soup du jour people want to focus on. But we really coordinate immunization activities among counties and city health officials, equipping health departments to address vaccine hesitancy, and then also looking to build vaccine confidence. And then we have the supporting local health departments and reducing disparities in adult immunization, the PAVE project, as well as vaccine access and training project. So there's a lot of things going on. And so just some examples of some of the projects that we've had come out of these is we're working for confidence with Johns Hopkins and the Institute for Vaccine Safety, and we built a landing page called Let's Talk Vaccines. There's a chatbot, lovingly named Vera, who will answer questions, any question that you might have about COVID-19 vaccine. We're expanding that to other vaccines. And then kind of what's come out of that is a lot of that we've talked about here during our time at NVAC is about trust. And we have had a backslide in trust with public health and local health departments. So how do we build trust? So it's kind of an interesting process. It's called a salon. Think back to the 1700s with Thomas Jefferson, and really coming together and talking about hard issues. And so we were trying to do that with Johns Hopkins. So we had our first salon to talk about trust. The next is going to be about civic engagement. And so there's a study out of the University of Wisconsin that says that really civic engagements, they tend to be highly or more vaccinated than other locations. So what does that play into public health? What does that play into the role of immunizations? So really trying to think of these broad strokes. Another thing that worked really well with some of these projects is the University of Maryland received funding, and they did shots at the shop. So shots at the barber shop for Black individuals. That was very, very successful in the Baltimore area. And so we've had a lot of good success there. I am missing some slides. I will just say that some other things that we're doing is a rapid community assessment. So that was developed by CDC, and we are doing rapid community assessments in local health departments. And then we're using that data to try to help build maps. So the slide that I'm missing is an ArcGIS map, my apologies. And so really looking at maps and trying to understand those vaccine deserts. So if I had my slide, if you Google CDC vaccine activity planner, there is a CDC map that was created by Esri, and there are lots of ArcGIS layers. And so really it's looking for like a coverage rate deserts and really targeting those areas. And then finally, I'll just end with, as I was talking about, one of our big things is putting out requests for applications. This is out now. It's another round of partnering for vaccine equity. This will be our fourth or third cohort, I do believe. And so for the scope of work, for A, $75,000 for a communications campaign to strengthen COVID-19 and influenza. And then the scope of work B is $150,000 to enhance communication campaigns, so a little bit more of an enhancement. And so applications are due June 30th, and then we'll get the money out the door and provide technical assistance as we go along. So I'm happy to talk any questions about what nature does, and with that, I will toss it over to Claire.
Thank you very much, Matt. Next presenter is Claire Hannon from the Association of Immunization Managers.
Thank you very much. Okay, good. Yeah, and just thanks very much for holding this panel. This has been really great information. You guys have been really great speakers. Just so much really great information at these meetings, and I think it's great to get all of this information out in the public to keep this discussion going. I'm Claire Hannon from the Association of Immunization Managers. We are a nonprofit, and our members are in the 64 awardee areas. So Dr. Peacock talked about how CDC sends funding out to the state and local and territories to do immunization work. And there are actually 64 awardees, 50 states, 6 major cities, and 8 territories or federated states. And all of those 64 have someone that manages and directs their program within the health agency, and they are the members of AIM. We have a vision for a nation free of vaccine preventable diseases. And basically what we do is we help our members, help those 64 learn from each other, address challenges together, work through new vaccine challenges. There's never a dull day in immunization. Just some basics about what goes on with immunization programs. And we are within the health agency. So as Dr. Allen talked about the state health officials in ASTO, the immunization program would be within that agency, so under the state health official. And we are as AIM an ASTO affiliate. And some of the things that go on, some of the things that the programs are funded to do with their cooperative agreements with CDC through the Section 317 immunization program, basic operations and infrastructure, so basic activities, addressing outbreaks. They manage the Vaccines for Children program, enroll providers, do storage and handling visits, track inventory orders, do all that work with the VFC program. And then mirroring what they do with the VFC program, we built the COVID-19 vaccination program. And I'm so happy that you talked about everything that we accomplished was very, very amazing. And then, of course, the outbreak control and strategies to increase vaccine coverage rates and working with the data. The immunization information systems in most state health agencies are housed within the immunization program and support all of the immunization programmatic activities. So I just wanted to talk a little bit about the environment with immunization programs right now. When we look at doing routine vaccination and getting back and catching up and getting coverage rates back up, it's just really important to understand what is going on in the public health immunization environment. And we have 64 awardees, and 42 of those 64 have new leadership, have new program managers since the start of the pandemic. So when you're talking about increasing routine childhood rates, even increasing adult rates, we have more than half of the immunization programs in the country who have never managed the program during a time when they were focused on routine vaccines. They've been focused on COVID. They've been focused on responding to the pandemic. And so we have a lot to learn. We have a lot of lessons learned to share. We have a ways to go to move past managing in an environment of putting out fires and doing something heroic to stop a pandemic. I also wanted to talk about the context of funding for the program. And this is the Section 317 program is the piece of the puzzle on the top that Dr. Peacock talked about. And this is what funds immunization program activities at the state and territorial level. It's a cooperative agreement with CDC, so it comes with a number of activities and requirements across the lifespan. The program has basically been stably funded for the last 10 years. It has increased a slight amount. And I say that because when you factor in inflation and you factor in new vaccines, you factor in enhancements to technology, to building inventory, to increasing data, you look at this funding level and you see that it has not kept pace with the need. And what it has not allowed for is a building of a robust adult program. So it's really focused on managing the Vaccines for Children program and implementing childhood vaccine activities. And so that's just important context to know. And then you factor in what happened with the pandemic and the investment that came with building the COVID vaccination program. When you compare that to routine programmatic activities, you can really see there was an incredible investment. And we got so much from that investment. All of those supplemental funds supported the partnerships, the community engagement, the building of trusted messengers, enrolling adult providers. We now have a network of adult providers similar to the network we have with VFC. They're required to submit data. So the data connections, the robust amount of vaccines, doses administered that we've collected through COVID, the connections with pharmacies, pharmacies being enrolled to give COVID vaccine and submitting data. We've just built an incredible network with this supplemental funding, and this supplemental funding ends. So that's a big concern for us. How do we maintain, these gains that we've made and this incredible network of adult providers? Dr. Peacock referenced the Vaccines for Adults program that is proposed, but it's just a proposal right now. And the reality is that this supplemental funding for COVID will come to an end. So just a little bit more about the environment and what's happening, what we've learned. We know that well child visits and routine vaccines have dropped. They dropped significantly early in the pandemic. We saw the ordering data that Dr. Peacock showed. The rates have rebounded, but the pandemic cohorts need to be caught up. And school requirements play a big role in making sure that those cohorts that didn't get vaccinated during the pandemic get caught up before entering kindergarten. So that's a big piece in any type of catch-up scenario. And then the jurisdictions are conducting various activities to get kids caught up before they enter school. Because that period before they enter school is when they can be very vulnerable to diseases. Some of the trends, and Dr. Peacock really covered this, but I'll just reemphasize the one thing she said about school entry rates going from 95 down to 94 and then down to 93. 93%, really incredible, but even that 2% drop is, as Dr. Peacock mentioned, 275,000 children. So that is significant. And, that's something we really want to address. And the other thing is that we have seen that children living below the poverty level and in rural areas have seen a decline. So I wanted to get specific into the data to show you from one state. And this is data from North Dakota, and it was provided to me by Molly Howell and her team. So thank you. But just wanted to show what is happening in North Dakota, and it's similarly mirrored in other states. So this is the percent of 19 to 35-month-olds who are up to date in 2019 versus 2022. And you can see that we have caught up. In North Dakota, they have rebounded for the series and for DTaP,
but still need to catch up with MMR, measles, mumps, rubella. And I think what's significant here is that this shows, well, number one, there's a cohort of children in between that are now in between the 19 to 35 months before they're entering kindergarten. So, you know, we need to catch those kids up. We have done really good work with the kids that are being born now and after the pandemic. We still need to improve. We still have that 3% difference with MMR. With adolescents, you can see, just as Dr. Peacock talked about, the rebound is not as strong with adolescents, and we're still behind with, well, particularly in North Dakota with Tdap and MCV4, but also Dr. Peacock mentioned we are behind with HPV. We still haven't caught up with HPV orders. We haven't caught up completely with HPV and other adolescent rates. So we have a ways to go with adolescents. And then this shows flu vaccine for by age group for the last 6 years. And the age groups go from the left side to the right side, youngest to oldest. And so you can see on the far right that vaccination for flu has actually gone up. So it's increased in North Dakota. So it's higher now than it was in 2017, the 2017-18 series. When you look at the children's rates all the way on the left, you can see that there were increases being made pre-pandemic, and then when the pandemic hit, the flu vaccination rates have gone down. So, and I think this is not just in North Dakota, this is a real trend across the country where pediatric flu rates have not rebounded, and it's a big concern. I'm hopeful that with RSV coming out, that one of the benefits will be increased pediatric flu and increased pediatric COVID vaccination. You know, if it becomes seasonal, that we can really have providers recommending strongly the vaccinations for all three of those every season. So I wanted to share this data with you to show you that it is a high priority. It is, in fact, the highest priority to address the routine vaccination rates for AIM members, so the program managers. So this survey is from last fall, so it was concluded in October of 2022, and we asked immunization program managers to talk about what their highest priorities are for the coming year. And you can see that their top priority was addressing low routine vaccination coverage rates. It's for children and adolescents. And so this is really good news that we sort of moved from a priority of getting pandemic vaccine out to now a priority of addressing routine coverage rates. This was before, you know, we had to come out with implementation of the Bridge program. So that's something that we're focusing on too right now, but it's good. So some of the activities that programs are conducting: increased collaboration with pediatricians, family physicians, pharmacies, schools, and other providers. I think that you heard earlier from Dr. Edwards at AAP that the environment for pediatricians right now is also fatigue, short-staffed, they're stretched thin. They need to be thinking about how to incorporate COVID vaccine into their routine activities, how they're going to incorporate that into VFC. There's a lot going on with providers, and so helping them to focus on routine catch-up activities, sharing data with them, looking at data where there might be vaccine deserts, where they might need to increase their activities. So that's the type of collaboration and discussion going on. Reminder Recall is sending out postcards to kids who may be behind, using your data to see, especially that cohort where we may have rebounded with the young kids being born now, that cohort that is vulnerable before they're entering kindergarten. Using school-located vaccination clinics. This has been a successful strategy for flu in many areas, and incorporating routine vaccines into those clinics. Using mobile clinics. Mobile clinics were something that we were able to invest in through COVID, and now using them at back-to-school events, at other events, getting clinics out into communities to do routine vaccination, not just COVID. And then again, just using that data to really identify where we need to make improvements. AIM has a reminder recall program that I wanted to share with you. We offer immunization programs to do sort of the brunt work of the reminder recall program. So to design with them the postcard, and then we use their data to send the postcard out to families that need a vaccination. And we've done this in 14 areas. And we've seen a 6 to 26% increase in vaccination for those that have received the postcard across those areas. And so we're going to continue to do this. It helps take the burden off, the postal burden, and take the burden off doing the work for immunization programs. This is an example of the reminder recall postcards. We're specifically focusing on adolescents because that's where we find the need is greatest. And then the last thing I wanted to touch on is that we just completed a series of 10 regional meetings that was specifically focused on increasing pediatric COVID rates, but it also lays the groundwork for increasing routine childhood vaccination rates. And we brought together the immunization program manager and their key staff in each of the jurisdictions in the region, as well as pharmacy representative, AAP, family physician, and pharmacy. And the concept was to have, and we showed them data about where their vaccine deserts were in their jurisdiction. And the concept was having the right people sit at the table and really work through challenges and come up with an action plan to address some of the challenges. If policy changes are needed in your Medicaid to recognize a pharmacist as a provider, for example, let's have the Medicaid person sitting there and talk with the pharmacy person and really work through this. And I wanted to share a couple of themes from those meetings. And the first theme that we heard very loudly and clearly is the fatigue and the short-staffed in pediatricians' offices, in family physicians, and with pharmacies. They're spread very thin, and the payment doesn't necessarily equate to supporting all of the effort they do, the counseling, the vaccine administration. It's becoming increasingly difficult for providers to give out vaccines. And we also heard a lot of success with pharmacists through the COVID program and discussion around where can we move forward with that? Where do pharmacists fit in with vaccinating children? They are able to vaccinate down to age 3 for COVID and flu through the PrEP Act right now, but then their authority is according to state law, and that varies by state. And we really want to build on their success, at the same time maintain that medical home. So all of those key ingredients, all of those important things, just discussing those challenges and how to move forward and how to really have an immunization neighborhood that supports catching up everyone on routine vaccines. So those are everything that I wanted to share with you. And again, appreciate having this panel and these discussions on catching up with routine vaccines.
Thank you very much, Claire. And I believe Matt, we've got your data slide that Rebecca's going to show here in just a moment. And I want to encourage, if anybody has any questions or comments for Dr. Ajayi, she's going to have to sign off fairly shortly. So I want to thank her for presenting the more global perspective on what we're doing to try to improve some of the catch-up and improve vaccination of vulnerable children worldwide and not just in our country. Are there any questions or comments for anyone? Any final comments from our panelists? We don't have any questions on the line or in the room. Other than, I want to thank all of you for your presentations. I think it's, again, as I've said for a long time, if we're going to ever have success in vaccination for our children, for our adolescents, for our adults, it's a team effort. And I think it's important that we recognize that our public health agencies, our program managers, our pharmacies, our physicians, our communities all have to be working together if we're going to get our families vaccinated and protected. Matt, do you want to comment on your data slide? Well, we've got it up now.
Yeah, so I just wanted to show that nature was really trying to help local health departments use data and use data visualization to really understand what their county or city looks like. And so we've done this on a bigger scale with CDC, and then we'll be teaching our local health departments how to use those data. So trying to always be data-driven. And thank you for finding this slide. I appreciate it.
Well, I want to thank you and thank all of the members of this panel. This is our final panel of our June NVAC meeting. I understand from Ann that we do not have any public comments today. And so with that, we will adjourn our June meeting. I would encourage all of you to please put our September dates on your calendars, and we look forward to another panel of great presentations and learning opportunities for all of us as we try to improve the vaccination programs across our country and beyond. Thank you all.
Produced by the U.S. Department of Health and Human Services.